All right, good morning. My name is Mary Leonard, Chair of the department, and it's my great pleasure to welcome you to today's Pediatric Grand Rounds in honor of Native American Heritage Month. On the left, you see your text code for CME credit, and we will put that into the chat for your convenience. Next slide. And of course, next week, no grand rounds with Thanksgiving holiday. So wishing everybody a very happy and healthy Thanksgiving. And then the following week, we're really delighted that John Bernstein is going to be describing the research with the Undiagnosed Disease Network. I think I mentioned last week with Grand Rounds introductions, how instructive this work has been. And John was part of a New England Journal paper that showed about a third of kids referred to the disease network ultimately get a diagnosis, in many cases, therapy. And so it's really exciting to see where the field of genetics is going. And then we're tremendously honored to have Alejandro Hoberman come join us. He's really absolutely a thought leader in evidence-based in general pediatrics. I know his work well, that everything he's been doing decades ago around treatment of UTI. And so he's going to speak about accuracy in the diagnosis and treatment of acute otitis media in young children. Really encourage everyone to come just because the methods that he uses, his research methods and study design are really instructive. Next slide. All right, and it's going to be that time of year. We're calling for abstracts for our 13th annual pediatric research retreat. Fingers crossed that this will be in person. It's really a wonderful opportunity for students, residents, fellows, postdocs, instructors, staff, and faculty of all disciplines to share the latest research developments in their field. It's a wonderful chance to see the full spectrum of work going on in the department. So that deadline is January 16th. Next slide. All right, and with that, I'm going to pass things on to Baraka Floyd, a clinical assistant professor and our associate chair for DEI. Welcome, Baraka.
Thank you. I'm so excited to have Dr. Shaquita Bell with us here today. Dr. Shaquita Bell is currently a pediatrician and interim senior medical director at Community Health Center, Odessa Brown Children's Clinic. Dr. Bell is a clinical professor at Seattle Children's Hospital and University of Washington in the Division of General Pediatrics. She completed her undergraduate medical training at the University of Minnesota Medical School, her residency and chief residency at Seattle Children's, and she's the immediate past chair of the Committee on the Native American Children's Child Health and a member at large on the board of the Association of American Indian Physicians. Odessa Brown's Children's Clinic has medical, dental, and mental health and sickle cell services and is grounded in community partnership. It operates a weekly vaccine clinic, accepts walk-ins for COVID-19 vaccines, and operates several mobile COVID-19 vaccine clinics. Dr. Bell is a member of the board of directors for the Seattle Indian Health Board, and she's well known for her work on racism and health equity. Among the many honors that Dr. Bell's received, the most recent includes Seattle Children's Faculty Teaching Award and the Best Maintenance of Certification for GATHER, which is focused on advancing health equity every day in 2018 and 2019. Dr. Bell's colleagues describe her as an amazing physician who makes people better at what they do, pushing people past the shock of historical traumas to really reflect on their own implicit biases on behalf of, and really to work to advocacy with their patients and making people better at what they do. So now I give you Dr. Shaquita Bell.
Morning, everyone. I'm so honored to be here virtually. We're going to cover a policy statement that the title is here. I try not to read my slides too much so that I'll keep you all awake this morning. But I'm really honored to be here to represent the American Indian Alaska Native month as well. Like, what an honor. I try not to make too many jokes about disclosures, but I will say that I don't have any financial relationship to what I'm going to present today, and I won't be going over any investigative or unapproved products or devices today. I do like to start my talks with a land acknowledgement. I think land acknowledgements have been a little bit controversial of late, but as a Native person, it is important to me to recognize that I am on the land of the Duwamish people, along with several other Coast Salish tribes. And the folks in this region have been here and are still here, and very strong representatives and protectors of the land. So I'm very, very blessed to be able to be in Seattle and to be connected to the indigenous populations of this area. Just to pause for a second, I wanted to ground us in the fact that I think many of us know the history and some of us don't know the present, and that's really where this policy statement is rooted in. But I want to go over language before we get started. So some people, a lot of people will ask me, how do I refer to Indigenous people? Is it American Indian? Is it Native? Is it Indigenous? And I think it depends on the person. A lot of people want to identify themselves first and foremost, just like we will with our cultural identities, with our gender identities, with our sexual identities. So usually if folks are talking about one person, I recommend that you ask the person you're talking about, or the group of people you're talking about, how they would like to be referred. Right now in our literature, like when you do searches and when we did work on this policy statement, most academic studies and most research uses the term American Indian or Alaska Native. And so we went with that for the policy statement, but within the policy statement, each author identified themselves how they like to be identified. So that's the language. I'm probably gonna jump around a lot. I usually refer to myself as Native or Indigenous. So that's probably what will slip out every now and then. The other reason why we decided to title the policy statement itself American Indian, Alaska Native is because we wanted to be really specific to Turtle Island. We did not include, for instance, Native Hawaiians because they are a distinct Indigenous population and they have distinct needs. And wherever possible, we try to be specific, like in terms of tribes or in terms of Alaska Native or American Indian, because all of these groups are really, really diverse. And these are our cultural, political entities, sometimes regional entities, and they're not, it's really hard to generalize. So I want to just have a beat of caution when I'm talking. I try to reference the study we specifically pulled on that. But please don't walk away from this talk thinking, all of these statements are just broad strokes for individual groups. And then I wouldn't be me if I didn't point out that I will use both health inequity and disparity at times during this talk. And disparity for me means just a difference. So, and truly, if you look at the root of that word, that's what difference means. So a difference between a group and another group. But I prefer health inequity because it really talks about what is just. I mean, that term gets more to whether it's fair, whether it's just. And so I try to use health inequities whenever possible. Partially just rooting this talk also in why are we talking about this? And I think in my many travels with the CONACH, the Committee on Native American Child Health with the AAP, one of the things that drives home the work of caring for our Indigenous children is that life expectancy in this country it can really vary based on where you're born and what cultural group you're born into or what racial group you're born into. And I guess that's worth a brief conversation too. I consider my Indigenous identity a part of my culture. I try to think of race as a social construct. So I'm Black and Indigenous, and that is how I identify, and that is my culture. But on a biologic level, on a genetic level, there is no difference between myself and another human on this planet. So when we see, for instance, this paper calls it disparities, but when we see inequities, those are driven by things like racism and other isms, and is not truly driven by biologic differences. And so that is the motivation of doing this work is one, because it's the right thing to do as a doctor to try to have people survive and to be as healthy as possible, right? But the other thing is, it is, you know, our jobs as pediatricians to set people up for healthy tomorrows. And part of caring for Indigenous populations is you are protecting culture, you're protecting language, you're protecting our existence. And so it's really a passion for the group that wrote this policy statement and so many people who care about these issues. So this is the title of the policy statement. You can find it, I mean, you could literally just Google it. It is through Pediatrics, obviously. And one of the things I like to point out is this is the first policy statement by the American Academy of Pediatrics that was authored by all Native authors. So myself, Dr. Dean, who is here in Seattle, is a med peds cardiologist. Molly Fuentes is a rehab doctor, and Kelly Moore is mostly a researcher now out of Denver. And we're really proud to come together and be the first policy statement authored by all Native Indigenous authors. And we actually acknowledge that in the paper, along with a bit of a land acknowledgement, which was really cool to do as well. As far as I know, that's the first time that's happened in a policy statement. And I think there was something, you know, very passionate about it. And I hope that if and when you read this policy statement or try to take the recommendations into your own practice or into your own environments of care, that you think about, like, well, how powerful it is for us to be present and to be seen and to not be invisible in this work, but also just to know that it's such a love language for us. And this is such a passionate issue. The other thing we do in this policy statement is we identify racism as a driver of health inequities. And we're really cautious to point out that much of the work that's done, especially with American Indian, Alaska Native data, is very white centering. So you'll see a comparison of American Indian children to white children over and over and over and over again. And it's really important to call that to attention. So the best way to do health inequity work, or specifically research, is to really look at what is our goal. What would we define as healthy, and not necessarily what another group such as white children are experiencing, because it assumes that what white children is experiencing is our goal, but it also centers whiteness and making that the ultimate goal. So a lot of this is really maybe philosophical or social, but I think it's really important. And now I'll get into the policy statement. So we covered a bunch of topics in this policy statement, and you could guess that each one of these could be an entire lecture in and of itself. I mean, where to even start with some of this? So I'm going to breeze over pretty high level each of these topics and then share the recommendations. I'll try to make sure that there's time for questions, and also just remind you to refer to the statement itself. If anybody's ever written a policy statement, you know, this is like 5 years in the work. So you can imagine how hard it is to summarize it in like 45 to 50 minutes. So I'll just remind us all of the importance of ACEs and how it goes back decades really to this work. And I know most of us on this call are pretty familiar with this, so I won't dwell on what ACEs are, but I just want to call out that many people link ACEs to later health outcomes. And having a cardiologist on our author list, it's really important to point out cardiovascular disease, and just recognizing that some of the long-lasting effects of ACEs is really bleeds into your adult health. And I think when I think of the microcosm that is our health, I think of our genetics at the center, but really if you stretch out, you can think of environmental factors, you can think of really population level factors such as racism, and you can see how this can drive towards how healthy someone is. And ultimately, as I mentioned before we really got into the policy statement, that what we're trying to prevent really is death. So obesity in North America, there's another interesting title, North American Indian Infants and Children. I do not use that term. I'm not, there's some of us use NDN, but it is really uncommon to see that as a little bit like, whoa, 2012, I guess. So just a reminder that obesity disproportionately affects American Indian children. So in this study, you can see it compared to other racial groups. And I think as pediatricians, it's not a large jump to understand that obesity is linked to things like hypertension and long-term cardiovascular risks. It is, it always strikes me as important to like really drill down into pediatric obesity to think about metabolic syndrome and what does that really translate to. And I think these are a couple of really good studies to point out that metabolic syndrome, diabetes, and cardiovascular disease are all linked. Oops, I went too fast. So early predictors of obesity and cardiovascular risk, BMI was largely determined by one. That's why this is our job as pediatricians to intervene and to address and to try to do something about it. I think the significant, or I don't think that I know based on this study, the significant predictors of BMI, it really start even before birth. And I think this is a really important factor into thinking about health is this wrap around like that we think, we think of health as both being prenatally, postnatally, historically, environmentally, your access to clean water, your access to affordable housing, all these drivers impact obesity. So breastfeeding is also really important. And I think that it is one of those topics that sometimes we do a good job of in pediatrics and sometimes it's a little bit of an afterthought. And I would push us to say, if you're working with American Indian, Alaska Native moms and babes or parents, because not everyone's a mom, it's really important to think about breastfeeding and know that it is really important and protective in preventing obesity. And there are a lot of reasons that access to breastfeeding or rates of breastfeeding are lower. And I think those are that, again, you could go into a whole hour-long conversation on breastfeeding in American Indian, Alaska Native communities. But we do know that it is really protective. And so we encourage people to focus on that as they serve these communities. We would be remiss with a rehab physician on our author panel to not talk about children with special health needs. And I think it's really, what I learned in doing this work is that kids who identify as American Indian, Alaska Native are at higher risk of injury. And I'll go a little bit into violence when I get to that part. But the other thing we really found is that they have a lower likelihood of being connected to services that would address their needs. So that was really concerning to me because I feel like you might not, I think it's really important to go upstream and prevent violence, but we know that kids have accidents or they're born with special conditions, and the ability to access care like physical therapy, speech therapy, those things are really related or really connected to academic achievement and overall mortality and morbidity. The other thing that's really interesting about studying this work is that culturally competent services for children with special healthcare needs who identify as American Indian, Alaska Native are also way more effective. So if you can connect folks to, for instance, services in their home community, in their Indigenous community, or that are culturally competent. So things like language courses, equine therapy, or being surrounded by therapists who speak their language or from their community is way more effective than sort of piecemealing a plan, although many of us have to piecemeal plan for all kids because we live in areas where there's less access to care. So switching gears a little bit to some of the violence, I put suicide and mental health under violence often in my head. So that's the natural transition for me. I think that'd be a bit abrupt on a podcast to go from children with special healthcare needs to suicide and mental health. But we, again, remiss to not talk about this. These are the big buckets of this policy statement in terms of things that are disproportionately or inequitably impacting Alaska Native and American Indian youth. And this one really hits home to me that suicide is the second leading cause of death for all youth aged 10 to 24. And I think it's such a preventable way for children to die that I think that's why it really hits home. The other thing we see a lot in American Indian, or really specifically tribal communities, is that suicide is a contagion. So many tribes will see this effect where one child will die by suicide, and then it becomes this disease that spreads throughout the community. And it makes a lot of sense culturally, because the loss of a tribal member, especially as a youth, is very detrimental, but it also introduces the concept of suicide as an option that was not previously thought of before. And so I encourage you to think about suicide contagion in all populations, and specifically in American Indian and Alaska Natives, because it is another way that we can protect our youth and protect our next generation, protect our language and our culture. And it is a preventable disease. The interventions for suicide, I think, and mental health in general, have been varied and variably successful. It does appear, again, like I mentioned with children with special healthcare needs, that focusing on a culturally competent and culturally humble approach is really important. So tying things to language, tying things to gathering medicine or other traditions and ceremonies is very effective for our youth. And this is a really cool trial work out of Alaska that focused on sorry, what's the word I'm looking for? Connecting. I don't know why that was a hard word. Connecting elders and youth specifically, and doing that around language camps. And it was very, very effective, which was really cool to see. And then they also used one of my favorite things is school-based health centers to do that work. And I can't say enough about school-based health. So I think when I did this policy statement, this is one of the sections that I contributed to. I think identity is so important to me. I think partially because I am at the intersection of so many identities myself, but I recognize that children who are at the intersections of a cultural minority along with a sexual or gender minority are at a much higher risk. And that's really the definition of intersectionality, is not that things are like 1 + 1 = 2 and 2 + 2 = 4, but when you are a minoritized group, or when you are a oppressed group and you have multiple identities that fall into that group, then those risks really start to amplify much faster than a tangential relationship. So two-spirit is a term that we use in Indigenous communities to try to capture gender fluidity. I think the concept of two-spirit and the concept of gender is a very complex conversation in Indigenous communities. And I could not summarize that in this talk, but I couldn't really cover it in depth in this talk. I will summarize it to say that pre-contact, gender and gender fluidity and gender identity was a very complex identity. And complex in that, I mean, it was not binary. So in our current American ethos, we really have a pretty binary language around gender, and that's shifting. I mean, I think most of us are becoming aware that there are more than two genders, for instance, but in traditional ways, in many communities of Indigenous people, even that concept is foreign. Like for instance, in the Dene or Navajo language, there's 7 different types or 7 different words to indicate one's gender. And so instead of trying to capture each tribal's specific terms and identities, there's this umbrella term called two-spirit, where we recognize that gender is a beautiful patchwork of part of identity. And I just call, I guess I pause on that to say that you might see that topic in this policy statement, or you might hear it elsewhere. And I think it's really important to understand the beauty of that term and the movement of the term through our community, because it is really important to be able to identify oneself externally that matches your internal identity. But it also helps us as physicians identify folks who are experiencing pressures. So the identity of being two-spirit or being transgender is not in and of itself a risk factor, but the societal pressures, the societal hatred, for lack of a better word, for transphobia and racism are what is really driving the inequities. But it is our job as physicians to intercede on that and to try to protect these youth and people. So I think this slide and these statistics speak for themselves. The two-spirit and transgender community, especially at the intersections of identity, experience astronomical rates of mental health and suicide issues. And it is really important to advocate for kids and youth who identify as gender fluid, non-binary, two-spirit, or transgender. So again, the topic of violence is a pretty robust one for me. I put a lot of things in there. I put racism, for instance, in the bucket of violence. You can also put obviously interpersonal violence, domestic violence, and things like homicide and vehicular deaths. But I think the important piece to understand is that people who identify as American Indian, Alaska Native experience higher rates of violence than other folks in these communities or in this country. And then I think the movement of MMIW and MMIWG, so missing and murdered Indigenous women and missing and murdered Indigenous women and girls, is one of the most important movements in our country today, at least for my communities. And if you aren't familiar with it, I really strongly, again, each of these topics could be a whole hour long or more conversation, or your PhD if you wanted to. And the bucket of MMIWG, or missing and murdered Indigenous women and girls, is really broad, and what I choose to focus on as a clinician, as a pediatrician, is trafficking. And I feel like that's a significant way that we can interrupt MMIWG as pediatricians, is thinking about how kids enter commercial sexual exploitation on an average age of around 15, but I have had patients as young as 9, and interrupting, preventing, and post-intervention is really important in addressing MMIWG around trafficking. I think the statistics around this can be really traumatizing just to even read. And I want to recognize, much like suicide contagion, experience severe violence like sexual abuse or commercial sexual exploitation, which are on the same spectrum, just with different words. It is forever impactful. And so I think Baraka mentioned historical trauma and how important it is to address that, but also to think about what we can do in continuing the health of a young person, and really being focused on trafficking as a pediatrician and in interrupting a cycle of violence and giving children the ability to understand that that is not a healthy relationship, that is indeed child abuse. And instead of thinking of the person who was solicited as the criminal, and really thinking of the person who is soliciting underage sexual acts as the criminal, we also address the disproportionate and inequitable criminalization of women of color in this country. And we've seen this throughout generations of history, right? We see this in the North American slave trade, that Black women, African-American women, were viewed as property and not as individuals. And it is really similar with Native women, that we were sold. And not to say that trafficking will only, or even being missing and murdered, it only impacts women or girls, but the focus or the emphasis of this work is around folks who identify with that gender. And I think it's just a natural connection, and it's really important to me to address this. And you can see how traumatizing or how detrimental this topic is for our children. So again, this is another topic, again, I feel like I'm on a broken record on this one, that you could talk about at length. We all know that foster care children who are in the system, who are reported to foster care, are very disproportionate. And primarily that is driven by racism and poverty, which is ultimately, poverty is ultimately driven by racism. We know that American Indian, Alaska Native kids are more likely to be referred to Child Protective Services and are more likely to be placed in out-of-home placement, which really disrupts an ability for a Native child or an Indigenous child to be connected to their culture, to learn from their elders, to learn ceremony. And that is a further driver of some of the things we've already talked about, like experiencing violence, like experiencing mental health and suicidality. The interesting part about foster care and trafficking, for instance, is so kids who run from care, so either from their home or from a foster care placement, are usually solicited for commercial sexual exploitation within 24 to 48 hours of leaving care. And that's like 57%. So it's really important to understand, again, this is another place where these things intersect, that addressing the trauma that foster care or interactions with out-of-home placement can further trauma in our children. And it also causes trauma within the community. And so what I try to work on, at least in Seattle, is how do we invest in the family upstream? How do we teach parents how to be parents? How do we give parents economic and housing stability in order to provide better and more safe conditions for children to live in? Okay, on to the real fun stuff. This is one of the things that I have really found to be very rewarding in my time on CONACH. So one of the things that our committee does is we meet once a year, pre-COVID, on Capitol Hill, and we partner with the Indian Health Service, or IHS, to advocate for specific legislation that improves the health of Indigenous children. And sometimes it's as simple as, fund the IHS, and sometimes it's as complicated as trying to help find a maternal child health coordinator for the IHS. It is truly been humbling to testify in front of Congress and represent our Indigenous communities, and specifically our Indigenous children. And what I've learned time and time again is that the federal government has not held up their end of the bargain. So for those of you who don't know, hundreds of years ago, like 300s and more hundreds of years ago, the federal government people came to this continent and enslaved and murdered millions of Indigenous people. And then fast forward a couple hundred years, the federal government created treaties with tribes, and I guess tribes also created treaties with the federal government to trade for land and natural resources, and oftentimes people and the blood of our ancestors, to get healthcare and education for our people. And so there's this trade, this trust agreement between the federal government and tribes that are recognized federally, which is a whole nother concept of the federal government provides federally recognized tribes. You can understand the problem with that statement. But so that is where the IHS came from. And I think one of the really important things to understand is that relationship, even just the 2-minute summary I just gave you, is fraught with issues. There is a lot of trust issues. It is not fiscally in the federal government's best interest to continue the legacy of American Indian, Alaska Native peoples. And I think it would be much easier if we were removed from this country for them. But now, thankfully, we're in a time where that's not really allowed or not really socially acceptable. And so instead, they really chronically underfund us and pass policy that is harmful. So this graph is, this one particular is a little out of date, as you can see on the date, but this has not changed. The way our federal government allocates money, it is on the yearly basis. So the IHS has a budget that lasts about a year, and you can imagine how challenging it would be to deliver services to healthcare for millions of people with a budget that's only a year long. Anytime the federal government goes on break or can't work together, that means all funds stop to IHS. And what I think hurts me the most in this graph is FEHB, which is the Federal Prison Bureau. And you can see the comparison of how we fund healthcare for American Indian, Alaska Native folks through IHS compared to how we fund healthcare for veterans and how we fund healthcare for federal prisons. It is frankly disgusting that that IHS is supposed to deliver healthcare to American Indian, Alaska Native peoples with less than $4,000 per person. And you can imagine what that leads to. It leads to trouble addressing any of these health conditions that I've mentioned and addressing any of the disparities and inequities that I mentioned. It leads to buildings that are unsuitable for providing healthcare. It leads to a really understaffed workforce, and a workforce that is phenomenal. I mean, the folks who work in IHS serve tribal communities, they serve rural communities, sometimes they're in cities, and they're really driven to that work. But you can imagine if you had a really good applicant for a job and you could make nothing working at IHS, or you could make a lot of money working at a private practice, how hard it is to hire and retain really good providers in IHS. The other thing that I have done a lot of personal work on, or sorry, not personal work on, many of us have worked on Medicaid, but this has been such a personal fight for me, is that many of our American Indian, Alaska Native children have supplemental insurance through Medicaid. So if you identify as American Indian or Alaska Native, you can receive healthcare through IHS, but 75% of folks who identify as American Indian or Alaska Native actually live in more urban settings. And so Medicaid becomes really important, and how Medicaid reimburses care directly connects to how available healthcare is, right? I mean, as a medical director of a clinic myself, I know how challenging it is to keep the lights on, to keep the heat on, when Medicaid is barely covering the expense of the services that we are providing. And this particularly impacts American Indian, Alaska Native youth because of where they live and because of the other drivers that I've already mentioned in this talk. Another thing that sort of we wedged in here a bit is along the lines of some of the complexity around legal jurisdiction. And if any of you have ever read Roundhouse by Louise Erdrich, I think it's a great book. It's a novel, so not true story, but it really handles these topics in a very beautiful way, because she's a beautiful author and a beautiful writer, but it also talks to the complexity and the trauma that this brings as well. So if you live on a reservation that might span, for instance, 2 different states, then you could have 2 different state laws, federal law and tribal law, and they could all be 4 different things. And we see this a lot in substance use disorder. And I'm particularly honed in on this because it's such a great example, but this happens in many other scenarios. But we often see, for instance, and I talked about this with commercial sexual exploitation as well, we also see disproportionate or inequitable, punitive, sometimes retaliatory treatment of women who have substance use disorder. And just like I want people to think of trafficking as child abuse, and that the perpetrator is the person who needs to be arrested, or the person in the wrong, and that's the person soliciting a child for sex, it is the same way I want us to shift our thinking about substance use disorder and understand it as a disease, instead of that parent that gestational parent is being a bad person. The way our laws work right now is that oftentimes women who test positive during pregnancy lose the ability to parent their child and will oftentimes also be incarcerated. And we talked about this. You can see the connection to how that becomes problematic in many of the things I talked about, right? So breastfeeding, that's protective for obesity. Well, if you are incarcerated and your child is separated from your care, then you are not able to breastfeed. And you might be saying, well, if you're on substance, you shouldn't be breastfeeding, but that's actually not true either. I mean, I think there's so much work around neonatal opiate withdrawal syndrome and addressing maternal child dyad and really thinking about the connection between a child and its parents and how important it is to protect that. There are ways that you can do that, but it is just an example of incarcerating a parent is just another step in how these disparities and inequities play out in our communities. And the other thing I would say is that the criminalization of people of color in this country is what continues to drive racism. So when we think about George Floyd, when we think about Breonna Taylor, we think about how just the very existence or the very perception or identity is threatening, and that it causes people to quote unquote be scared and to react violently. That is all perpetrated in the messages received throughout our lifetimes, and part of that is that over incarceration and seeing people as criminals. And I think this is really important, especially in pediatrics, to think about a place where we can interrupt that cycle and really think of parents as being a unit that's protective for children with support. Now, I don't mean to say that all parents are great. There are certainly parents who should not be parents, but that number is really low. And I think 15 years now into practice, I can confidently say that I have cared for thousands of children and thousands of parents of those children. And it is rare. I can count on one or two hands of how many times I really believed in my heart of hearts that a child should be separated from their parents. So I am not speaking in absolutes, but I do think that this is a place where we could intervene. Obviously, in this policy statement, we couldn't cover everything. We nodded to a couple of other things like oral health, otitis media, and asthma. I just want to be cautious to say that it was really hard to meet the word and page limit for pediatrics, and that you could talk forever about how amazing and how special our communities are. And I think if you walked away from anything from this talk, I want people to understand that American Indian, Alaska Native people are everywhere, that we are here, that we're not just in museums or in history textbooks being brutalized, but we're sitting across the table from you, or we're sitting across the exam room from you. And it's really important to educate yourself on these concepts and to make sure that you're aware of the importance of our job as pediatricians. So I'll go through the recommendations. I'll keep it a little bit brief because I'd like to have plenty of time for questions and discussion if you'd like. And also reading text is pretty painful in a slide presentation. So I think I won't read every word to you, but the overarching theme of our recommendations is one, that Indigenous communities hold the power, the strength, the knowledge for generations on how to take care of ourselves and our people. And anytime we want to develop, and by we, I mean the medical community, pediatricians, healthcare providers, want to develop an intervention, we should do so in partnering with the original peoples, because that knowledge is there, and because we even know in evidence-based studies that connecting to culturally appropriate interventions is what is going to be the most protective. I think there's a lot of really great solutions already out there that would be great to share more broadly. Things like early childhood services, nurse family partnership, Head Start, Reach Out and Read. Those are all programs that are successful for all types of kids and should be applied in many different communities. I think it's really important to assess. I feel a little bit mixed about assessing for ACEs if you're not going to intervene. So I'm not quite, don't kill me, California. I'm not quite in the universal screening, parade yet, but I do think it's important to have conversations. I'm a primary care pediatrician, so I get to know people over the lifetime. And so oftentimes I do address ACEs or social determinants of health over a lifespan. And I try not to approach it as universal screening, but rather a conversation that develops over time, because I think families can have, we all have different times in our life where drivers such as financial security are impacting our life. So we'll put a pin in that. We can come back to that in questions if we want, because that's a loaded one for me. And then really thinking about, how do we preserve our culture? How do we stay connected, have our children stay connected? Things like promoting breastfeeding and really partnering peers and peers. So connecting elders or people who have had children with people who are new parents, and how important it is to learn through each other on how to tackle things we might not know. I always make this joke that kids don't come with an owner's manual. It's really hard to know how to be a parent if you've never learned how to be a parent. And that's one of the wonderful things that we can certainly do as pediatricians, is help parents be successful in their parenting, which lowers stress, which lowers the impacts of the external environment, such as racism and poverty, and creates a family union that is really protective for the child. See, I knew that was going to happen. I tried to slow down on my going forward. This is just a nod to making sure that we have good services for children with special healthcare needs. And I think the medical home is a great model of that, of partnering with a community and a primary care provider who can help make sure all these services are really wrapped around and we're not missing gaps, or that the patient and family really own the agency over the health, and that they're informed and know the direction in which things are going. I think it's important to think of substance use disorder as another healthcare diagnosis, just like diabetes would be, or obesity. And so approaching substance use disorder in that way can be really helpful to decriminalizing it and taking away some of the taboo around discussing substance use disorder. As a child of an addict, it was really important to me to come on this journey. I mean, I'm an adult now, so and a physician, so I can conceptualize it a lot better. But at the end of the day, even though one of my parents was in and out of rehab and in and out of jail, I still love them just as much as anybody loves their parent. And so the idea of them being treated as a bad person or as a criminal was really hard for me. And the idea of being separated from them was very challenging for me. And I try to remember that when I'm working with patients and families who struggle with substance use disorder and their families, that is still their family. That is still what they know as being home and who they love. I think it's really very important to offer gender affirming care. I hope that's obvious the time that I spent in talking about two-spirit youth and transgender, non-binary, and gender non-conforming youth. It is our job to create as affirming of an environment for our patients, but I also would encourage you to do so for each other as well. I think just as much as our patients and families are important to us, our community and our family are also the people that we work with. I mean, I don't know how most of you practice, but our MAs bring our kids to our clinic, and our front desk staff bring our kids to our clinic. And so everyone is important in our building, and we want gender affirming care from the time somebody parks in the parking lot to the time that they leave and go back or to their bus stop. It's really important to address trafficking, and I talked on that. I'm happy to come back to it if we have time. It is our job, and I know it's really daunting. When I started on my first journey of really thinking about policy and going to Congress and talking on the Hill about legislation, it's very intimidating. And I think part of that is intentional, and part of it is just really understanding the difference between institutional racism and structural racism. And I try to bucket those two, of thinking like, what can I do in Seattle? What can I do at my clinic? What can I do at my hospital as being institutional? And really thinking about what are our federal policies, our legislative opportunities to advocate to address the structure. And things like that include Medicaid include the school to prison pipeline, and really thinking upstream and how do we intervene in that can impact the largest amount of people. If you could do one thing, I would encourage you to advocate for adequate funding for the IHS. I think I pointed out that how important that is and how underfunded it is, which directly drives how care is delivered in many tribal communities. It's important to address things. We didn't really even get to homelessness or living with in locations where housing insecurity is an issue, but that again could be a whole nother concept or a whole nother talk. And we recently published in APA article on how poverty impacts Native communities and how it is just another driver of these health inequities. And then really thinking about how do we fund Medicaid? I think that is important for so many of the communities. I could argue, or I bet without arguing, that many of you on this call understand the importance of Medicaid and to never give up our fight to have kids protected and have all kids have access to healthcare. And then working with local and state laws and law enforcement to address disproportionate incarceration rates for people of color is really important. So I'm going to stop there. Wow, I stopped right on time. That's really impressive. Make sure we have some time to talk. I just really appreciate being here today, and I know we covered a lot. So happy to have a discussion, and it looks like there's a few things in the chat or in the Q&A as well.
Yes, thank you so much for really adding context to the policy statement. So our first question is, BMI is somewhat controversial. It's meant to be a calculation that was designed for use in Caucasian Europeans or white Europeans. It can be discriminatory towards other groups. Why do we continue to use it? Why not a different measure?
Yeah, that's a great question. So as I said up top, a little bit of our limitations in writing this policy statement, I think the themes are really important, but in terms of backing it up with papers or with existing research, we were limited to what's already been done and the way that studies are done. So while I totally agree with you, BMI is very problematic. At my clinic, we try to use WHO instead of CDC because it was a more diverse population in being built. But I think it's also important, like in my day-to-day practice, when I talk about weight and height and growth, I really try to center that in body positivity and really center that in what is health. But the reality is a lot of the studies that we take this work from use BMI, and I think it's a great call out. I think moving forward, like I'm a clinician, although I support and help and have published, obviously it's not my primary work. If I were to do a study, I certainly wouldn't use BMI. I think it's one of those things that have been a proxy for years, and it's just like trying to use Medicaid as a proxy for race or for socioeconomic status is really problematic. I think BMI is the same way. So thanks for bringing that up. It's a really important concept to make sure we're aware of when we're doing this work.
Yeah, I think it's also another great example of centering whiteness.
Yes, absolutely.
Another good question was, why is there so much substance abuse in the American Indian, Alaskan Native populations? Is there a genetic factor, or is there more of a psychological factor? Right.
Okay, well, you can probably guess what I'm going to say about the genetic factor. No, that's not a thing.
Race is a social construct. So.
Thank you. Thanks for having. So absolutely not. I think that much like what we've already talked about is this idea of. Let me back up and say the next thing I'm going to say is not very PC, but I think it's really important to confront stereotypes head on. So a lot of times, I think people who identify as American Indian, Alaska Native are portrayed as being drunk or is portrayed as having disproportionate rates of substance use disorder and specifically alcoholism. When you actually step back and look on a population level, it is pretty comparable. So there is no genetic driver. I do think historical trauma and trauma of all types again, fits into that milieu. So if you think about your genetic biological potential as being the center of this universe, and then you think about your home, the neighborhood you were raised in, your personal behaviors, whether you smoke, whether you exercise, whether you drink water, and then you scale back to institutional policy or your regional health, and then you scale back to really big isms like racism and transphobia. You can understand that substance use disorder may fall in any of these categories. It doesn't fall in that center, but it can fall in behavior, and it certainly can be driven by environmental factors and even bigger factors by racism. So I think that's probably where the root is. I instead of really thinking about substance use disorder as being this rampant plague on our communities, I rather like to focus on how do we address trauma, how do we address racism, how do we address the social drivers that create behaviors that are oftentimes just coping mechanisms, and really thinking about the way we conceptualize substance use disorder as being a disease in and of itself. And if we can shift that narrative, then we can really bring support services to people who are struggling with any disease. I'll stop there because there's a lot of great questions, but that's a topic I could go on and on about. I feel like I've said that about a lot of things today.
I think the other contextualizing factor, right, is when you think about racism as an adverse childhood experience, and we know that adverse childhood experiences increase the risk for substance use disorder in and of itself. And we know that populations of color experience racism at a higher proportion. That also is something that we have to take into context as well, which you stated.
Yeah.
Then another great question was, what are some of the best or most effective ways that we can advocate besides voting? For example, calling or emailing senators or donating to certain PACs or such.
Yeah, great question. So I think the way that I have been most able to access this is through the AAP. I think so. I don't work for them. They're not paying me to say this. I feel like I have to say that. I had that disclosure slide, but they have both state and federal legislative groups, and they can really connect you. So either through your chapter or through governmental affairs in the academy, they can connect you with very specific policy that is impacting our communities. And so one of the things I think about is the recent work by the academy on children who are in foster care and services, and really pushing for family first, and how do we teach parents how to be parents, how do we keep a family unit together. That can happen in our hearts, that can happen in our behaviors, but that can also happen through legislation. And so connecting with your chapter, connecting with state and governmental affairs is a really great way to very easily be added to thousands of pediatricians who are looking at one specific bill or looking at how we're funding one specific initiative, and really feel like your voice is important. I think calling your senators and having a relationship with both your state and local leaders is important, and the way to understand what that political atmosphere or landscape looks like or what is happening is to stay connected with a larger source. I just don't personally have enough time to know what bill is going to what place, how often, and so it's nice that we have these groups that are kind of keeping us all aware of it, so that we can be really focused in our intervention. Especially as healthcare providers, we're all so busy that if I can just get the weekly briefing from the academy and say, hey, they really want me to reach out to my state senator this week about Medicaid, then that's what I can do. And sometimes it's easy as clicking and signing a letter to your senator. And at most chapters, the Washington chapter actually has a legislative committee that's really effective, and you can partner with those folks to understand what's going on a local level.
Thank you. There's obviously justified mistrust in the healthcare system and historically oppressed populations. Do you have particular considerations that you have in understanding vaccine hesitance in your American Indian and Alaskan Native families?
Great question. I will say that I'm going to not center whiteness, but compare American Indian, Alaska Native peoples to the rest of the country. We are highly vaccinated. We're at like 85, 87% on a national level. So for COVID, excuse me. And the IHS actually, for routine childhood vaccines is higher than the national level too. It is really like in the mid 80s. So it's actually not as huge of an issue in American and Alaska Native communities, vaccine hesitancy. And I'm always cautious with that word because I think with COVID, it was also about vaccine access and information. But one thing I have been pushing COVID shots, as Baraka mentioned, COVID vaccines are really, really important to me, is to help people understand that this is a global phenomenon, that this is bigger than the United States government, and that COVID is really affecting all of us. But what I think is really cool and really protective and part of what was such a driver for how well our tribal organizations vaccinated their people is that we understand, is part of the cultural milieu and part of what we're taught in our ceremony and in our tradition is that what is good for the greater good or for the we is more important than what is good for me. And so many of us are vaccinated because we want to protect each other. And sure, it's wonderful that that protects me, but it's more important that it protects my elders. It's more important that it protects my language. It's more important that it protects our children. And so I believe that that concept is the reason why American Indian, Alaska Native people are actually higher vaccinated than just about any other racial or cultural category in this country. The other thing is that federal tribes and tribal organizations were able to get COVID vaccine directly from the government so that they were supplied early and with enough vaccine to actually vaccinate their community and then offer to vaccinate other communities. So great question. Thanks for letting me highlight that wonderfulness.
That's amazing.
Yeah.
One of the things that's a conflict or more of a difference in understanding is there are some folks that have been talking about genetic susceptibility to explain some poor outcomes in places like the NICU, while others are stating that there are no genetic drivers for poor outcomes. So things like food deserts that drive obesity. How can we rectify those differences when we're thinking about our discourse in this new space where we're trying to really consider health equity and the drivers of health inequities and disparities?
Sure. So this is a little bit of a loaded question. I could spend an hour on this. Race is a social construct, period. There is no genetic basis, period. What I will say is that epigenetics, so the stressors on our genetic codes, can be driven by so can be driven by racism and poverty. So if you think about just DNA, just the weave of DNA, if you're being insulted, if that genetics are being insulted by racism, by environmental racism, by poverty, it will lead to changes on the epigenetics level, which you can then pass on to your children. But that has nothing to do with the identity in and of itself and has everything to do with these social drivers that are impacting genetics. So the topic of epigenetics is not really about genetic susceptibility. It is really about these environmental factors that impact our health on a genetic level. That's a fast way of saying that. I do think there are also regional contexts, right? Like, so people who want to discuss race as a social construct with me will say something like, well, how come only Black people have sickle cell? Well, first of all, that's an incorrect statement. They are not the only people who have sickle cell. But what we know about sickle cell is that it's really a regional difference that was driven by environmental factors such as malaria that cause a genetic shift in that region. And that region happened to be in Africa. So it is not connected to a racial identity. It is really connected to a region. Maybe that helps clarify the difference.
Yeah. Thank you so much. And then just lots of gratitude for your presentation today.
Oh, thanks. Yeah. I'm so glad to be here. I'm seeing some familiar names in the post, and that's really awesome.
There's one last question, if we have time, that we can leave on the recording for folks to hear. As a pediatrician and clinic medical director, the particular pre-visit questionnaires, like Bright Futures or one that you developed, that you prefer to help identify important topics of discussion for the families that you serve?
Yeah, such a great question. So I can't take credit for this. This was done by the previous medical director. But what we've done in our clinic is partner with our community and a parental advisory board to take things like Bright Futures, SOGI, SDOH, and think about how can we make a screener that is culturally competent and also ask questions in a non-traumatizing way. So trying to make sure it's trauma informed, which is really based in relationship and language and validating emotions, and also making sure it's culturally competent. So I'm happy to share, that's my email there. I'm happy to share our screener with Epic. So we rolled out Epic about a year ago, and we've been able to take that screener and start entering some of that data into our EMR, which will be really interesting to look at it on like a population level and start connecting that data. But it's such a great question. And it really came from a complex way of training, for instance, our front desk staff to ask for pronouns or preferred name versus legal name. And then how do we ask about firearms, for instance, in a trauma-informed positive way? Like there are all these nuances of pulling that together. And frankly, the point is that we did it together with our community and with our patients and families so that we could make sure we asked in a way that was helpful, and that we were really doing it to get to know the person as their identity and to get to know what their protective factors and their risk factors are, and not just address our own agenda or check a box that we were told to check.
It really allows you to kind of dig into making culture protective.
Yeah.
Yeah.
Which I think is actually, I didn't get to say this, but it's really protective for us as practitioners too. So I believe one of the ways to combat burnout in an individual provider is helping us be connected to the beauty of our culture, to help us be connected to our language, to our ceremony, to our food, to our spirituality. That is so protective for the patients that we're serving. We should provide that love language for ourselves as well.
Thank you so much for sharing. Thank you so much for your informative talk today.
Yeah, thank you all.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.